Good afternoon from me. Andrula, thank you very much for your kind words. It's really a great honor for me to be part of this great scientific meeting. And before I share my experience, I would like to give some details about the situation in thalassemia in Greece. In my country, there are about 3,000 patients with thalassemia major and intermediate, and about 1,000 to 2,200 patients with sickle cell disease. Although we have approximately 370 MRI scanners throughout the country, there are only 4 or 5 private centers providing T2-star measurements, and only one in public hospital running a complete thalassemia protocol, which is our center. We'll know that there is a global lack of radiologists, which is, I suppose, in the other countries. And as very well Professor Pierre mentioned, these MRI staff techniques are too complicated and are not really challenging for the radiologists to be involved. On the other hand, unfortunately, FERRIScan is not covered by our national insurance, so it's too expensive for the patient to pay themselves. Now, in the next 15 minutes, I'm going to share our short experience. We're a small center, but we are gaining great experience, which I would like to share with you. So we have a comprehensive approach of thalassemia with a multi-parametric MRI protocol, both in the heart and the abdomen. And we of course quantify the iron in the heart using the T2-star technique. We provide basic cardiac function analysis, and recently we have started providing some advanced MRI techniques, such as the T1 and T2 mapping, the myocardial strain, and in selective cases, we administer contrast for the late gadolinium enhancement assessment. Now in the abdomen, of course, we quantify iron not only in the liver, but as well in other organs such as the spleen, the pancreas, the kidneys, and the bone marrow. We routinely use the T2-star technique. We have the dedicated sequences and software from Siemens, which is called MyoMaps and Liver Lab, and we use the FERRIScan for clinical trials. We also quantify the fat, and then I'll explain later why it's important. And recently we have incorporated the T1 mapping in the liver, and of course, what I think it's more important, we have added some dedicated images to detect focal lesions, especially in the liver. So starting from the heart, we usually start with the cine images to have a cardiac function overview, to assess for any wall motion abnormalities, the thickness of the myocardium and the ventricular septum, and any profound valve regurgitation. So we have a good overview of the cardiac function, and these images are very useful to our cardiologists. Later on, we quantify some basic CMR parameters for the cardiac function, such as the end-diastolic volumes, end systolic volumes, the stroke volumes, and the total mass of the heart, which of course are normalized for the body surface area. We usually have the cutoff of 60% for the ejection fraction, as we know that this parameter is altered only at the later stages. So below the 60%, we raise a yellow card to the cardiologist. As I said, we use the dedicated Siemens software for the T2-star. So we know that the T2-star is a very important stratification factor. So we want to know if our patient is in the safe zone above 20 milliseconds or is in the danger zone below the 10 milliseconds. We also know that the T2-star, as it has been shown before, is an excellent predictive biomarker. So when the iron is high, the risk for unwanted significant cardiac events in the terms of heart failure or arrhythmias is very high. So we know that at the level of 6 milliseconds, when the T2-star is so high, is so low, there are great, almost 50% possibility for a patient to develop heart failure in the next 12 months. But in the meantime, newer biomarkers, especially in the CMR, have been developed. There is, in the later years, there is great research for the myocardial strain, which is an index, a CMR index, to assess the contractile function of the cardiac, and mainly in the left of the left ventricle. So we use the global longitudinal strain of the left ventricle in order to predict, let's say, as a preliminary factor, which could predict, early predict cardiac dysfunction. I'll give you an example. We have this 24-year-old female with beta thalassemia major. The T2 star is very low, it's 8.2 milliseconds. And the left ventricular systolic function is preserved as the ejection fraction is 61. But on the other hand, this patient has very low global longitudinal strain of the left ventricle. It's minus 13%. We have a cutoff value about 18%, and this should be this patient should be monitored very, very closely, because there is a great possibility to develop any unwanted heart failure. We know that the T1 mapping is a complementary tool to assess iron in the heart with the T2 star. And there is some evidence that it might detect some missed iron, especially in the range between 20 and 30 milliseconds that otherwise was considered normal. And this is possibly could reflect maybe 30% of these patients. But of course, to assess the clinical significance of this level of low T1 and normal T2 star needs further evaluation and further studies. We don't routinely use gadolinium for our routine protocol, but in some selective cases, it can give results that with no other way we could discover. For example, this is a male of 47-year-old with sickle cell disease who had normal cardiac function and some arrhythmias, and we were asked by the cardiologist to assess for any myocardial scars, and we see here these diffuse myocardial scars, and honestly, there would be no other way to assess this pathology. So it's another complementary tool, especially now with this increasing rate of the myocarditis due to COVID. So in the abdomen, we all know that the measurement of iron in the liver, it's very important, and we've seen why, because the liver in the iron reflects the total iron burden, and also it has a great prognostic value, not only for liver complications, but as well for cardiac complications. And of course, the iron load in the liver has direct impact on the overall survival. So we routinely use the parametric maps with the T2 star technique, and we calculate at least at 3 different levels in the liver. As we know, the T2 star technique uses a single slice, not multiple slices as the first scan, and we want to assess at least at 3 to 5 slices in the liver. Of course, we measure T2 star in the pancreas, the spleen, and the kidneys, although in the kidneys we rarely found any iron, and of course in the bone marrow. And I'll give you some examples why we consider that this is important to do all these measurements. We have some patients, in most of the patients, we have slight differences in the iron between the left and the right liver lobe. Possibly it could be due to some kind of strange hemodynamics. And this at some time may be more profound as in this patient, when we see that the iron in the left liver lobe is much higher than the right, because we have a signal drop in the in-phase images, and this parametric map shows it better. In the left liver lobe, we have a T2 star of 4.5 milliseconds, and the right liver lobe, it's about 7 milliseconds. It's not usual, but it's about 5 to 10% of the patients that present with this case, and that could partly explain this this distribution of all these calibration curves, which were controlled against biopsy when using the T2 star. Is there any value to quantify, to try to quantify the iron in the rest of the organs? Let's see an example. We have a 49-year-old patient with thalassemia major. He was not good at all with his chelation. He had a very high leak. And then he convinced to start an intense chelation therapy. And about a year later, we had a significant drop in the liver. But we see that this patient has high iron levels in the spleen and as well in the bone marrow. So if we had to take a clinical decision only from the significant liver improvement, we might have forcibly relaxed this intention chelation regime. Another value is that we can assess the patterns of iron overload. We know that there are specific patterns that the iron accumulates in the organs. So in the transfusional siderosis pattern, we know that the iron, due to the form of hemosiderin, usually is uptaken by the cells of the reticuloendothelial system, the Kupffer cells in the liver, as well as the rest cells in the spleen and the bone marrow. This is a typical thalassemia pattern with high iron overload in the liver, the spleen, and the bone marrow. There is a second pattern, which is the non-transfusional pattern. Usually we see this pattern in the primary hemochromatosis, the thalassemia intermedia, and other hemoglobinopathies which are not transfused. And in this area, there is no iron in the reticuloendothelial system because the spleen here is clear. But on the other hand, we have iron in the pancreas and in the liver. And there is great possibility that this iron is not in the Kupffer cells, but in the hepatocytes, which is potentially more toxic than the iron that is accumulated in the Kupffer cells. So in this case, maybe it's important to assess this high iron levels and the toxicity. So is it important to quantify fat in the thalassemia? Yes, we believe, because the fat is another the predisposer for the developing of steatohepatitis, cirrhosis, and hepatocellular carcinoma. And in patients who already have iron overload and various infections in the past from hepatitis and other complex medication, we don't want the presence of another factor that will cause more problems in the liver. And let's see here an example. We have a 15-year-old male with thalassemia intermedia. He's plenectomized. There is no iron overload, but there is diffuse liver steatosis. This patient had an uncontrolled diabetes. We see the significant signal drop in the out-of-phase images. And after visiting the endocrinologist, 12 months later, we see the significant improvement. So it's like the iron, we have the iron in the liver, you take the chelation therapy, you get rid of these confounding parameters. Is there any role of T1 mapping in the liver? Well, possibly not, or at the moment. Usually when we have only iron, the T1 is decreased as the T2 star. But because when there are complex diffuse liver conditions such as hepatitis or fibrosis, it tends to increase. So for the moment, we don't have any good information of the role of the T1 to quantify iron. Of course, there is this excellent software from Oxford, the liver scan, which uses the T1 and the T2 star combination to assess and quantify not only the iron but as well as the fibrosis in the liver. And I will spend the last couple of slides for something that I think is very important. We'll know that later in the last 10 years, there is an increased rate of hepatocellular carcinoma. And the early detection is crucial, as we cannot do anything to avoid it. At least we can early detect it. And we know that the ultrasound and the alpha-fetoprotein, which are used for surveillance, are not adequate. So we have implemented some additional images in our protocol, which cost about 7 minutes. These are the last 7 minutes of the examination, which are the T2 star high resolution images, and the T2, not T2 star, T2, and the diffusion images. So I'll give you a couple of examples. Here we have a 52-year-old male with beta thalassemia major. He came for a routine iron quantification. His last scan was 2 years ago and was negative. His ultrasound in the 6 months ago was also negative. This patient had a very low iron concentration in the liver, but we incidentally discovered a lesion with intermediately high signal in the T2 images. This lesion showed a restricted diffusion. We decided to inject contrast, and we see that there is arterial contrast uptake washout in the portal venous phase, and this slight rim enhancement in the 3-minute delay phase. All these imaging features are very suspicious for hepatocellular carcinoma, especially in a patient who had a chronic liver disease. And because this lesion is below 2 centimeters, we cannot call it a Lyrage 4 lesion. And he went for MDT discussion, and because this patient was a doctor, he decided that he wanted to get rid of this and went for RFA. Another patient, 49-year-old male with beta thalassemia. He came for routine iron quantification. His last scan was 13 months ago, and he missed his ultrasound 6 months ago. Practically, he had no iron concentration. We incidentally finding another lesion here in the segment 5, intermediately high signal in the T2 images, diffusion restriction. Again, we injected contrast. Arterial contrast uptake was out in the portal venous phase, and rim enhancement in the 3-minute scan, and went for MDT, and the decision was to follow up in 3 months with the use of Primoris. So this is our short experience in the hepatocellular carcinomas, and by adding this set of images in the last 7 minutes, we were managed to detect 6 cases of hepatocellular carcinoma and intrahepatic cholangiocarcinoma between the 1.5 and 2.5 centimeters. And moreover, we managed to discover early 4 cases of renal carcinoma with a diameter below 4 centimeters, and these were candidates for partial nephrectomy instead of radical nephrectomy. So some final comments. T2 star is a widely available technique, and it's an accurate tool for iron load assessment, but it seems too complicated and not attractive for the radiologist to get involved. And of course, as we know, in experienced hands could be disastrous, and there is a need for more simple to use and lower cost tools. There are new imaging biomarkers that would have a great role in both the cardiac and liver analysis, such as the myocardial strains, the T1 mapping, the late gadolinium enhancement, and possibly the T1 in the liver. And I think that the early detection of focal lesions is of utmost importance, especially in the liver. And with this, I would like to thank you for your attention.